Thank you very much, Dr. Savani. It's very hard to follow Alice, but I will try to do my best. So Alice set this up very nicely and trying to identify why follow-up is important. So what I'm going to focus on in my talk is sort of the process of how to get them to follow up and how to get them out of the NICU. And as you've heard, that there's an ever-increasing number of medically complex, technology-dependent patients that are being discharged from our NICUs. And so we have to recognize that this is a population of infants that are more likely to be readmitted to the hospital within the first year of life or have frequent emergency room visits in the first year of life. And so there's a huge burden to the healthcare system. And so we need to institute processes that are smooth, that address this population, and utilize best practices to try to have that smooth transition so we can decrease readmissions and ER visits and what have you, and improve outcomes if we can get them to the follow-up clinic. So discharge is no longer simple the way it was maybe 10 or 15 years ago, and we have to make sure that our processes match that. How many people have a standardized discharge transition process at their institution that may have been modified in the last 5 years? So there's a few hands. That's good. So Dr. Spears said this, I think it was yesterday. He said that we have to recognize that the journey after NICU discharge is fraught with potholes. It's Dr. Spear, we know how he speaks, so, and it's true. So, is he there? Oh, there he is, all right. Did I quote you correctly? Okay. So the continuum of care for NICU patients and their families does not end at the time of hospital discharge, and Alice outlined that. It's the beginning of another phase of their journey. And the discharge process, wait, let me make sure I get that. There we go. So the discharge represents one of the most critical transition points in the life of a NICU. I use graduate NICU survivor. I should correct my slide. Follow after weeks and months in the NICU. So it starts in the fetal period, especially if there's been an early diagnosis of an anomaly, and they take that journey through the birth hospital to the NICU and then discharge. So that's a very critical time period. And it is vital for us to ensure that that transition from NICU to home or NICU to follow-up is smooth to decrease readmissions, emergency room visits, and improve outcomes. So how do we define transition? Care transitions is really an action. It's a series of processes that ensure the coordination of care, continuity of health care for these patients as they move through different levels of the system. And we heard yesterday about the small baby program. They move from the small baby unit into the NICU, so that's one transition of care. They move from the level 3 status to the step down level 2 status, and then getting them home. So there are multiple steps along that transition where things can go awry. And we know that there's a lot of variation within hospital systems in terms of that process itself. So we know it represents a vulnerable period and the potential to impact long-term outcomes. So who are the kids that we're most focused on? It's the medically complex premature infant who has a number of subspecialty visits that are needed to be put into place, and they're technology dependent. They have G-tubes, trachs, vents, et cetera. And those are the kids that have been in the hospital for a long period of time. So frequently they're coming out of our level 3 and level 4 units. So when we look at the whole process and the challenges that we face in optimizing the transition, there's sort of an integration of multiple factors. There's the individual level, it's the patient and their family, and then the system itself that has to be well integrated. And then, as Alice indicated, we have to look at data metrics. We have to be able to identify what are the key metrics that we can look at to determine if the transition process is efficient, if we're getting the outcomes that we want, in addition to evaluating potential cost savings. So all those have to align. And so when we look at the potential identifiable barriers to discharge before they leave, there are numerous. And these are slides that were provided me by Dr. Laura Rabinos, who's at UT Southwestern. Well, who was. Now she's in San Francisco. But one of the things that we identify is the multiple handoffs. So there's often, even in an academic center, when we go from one month to the other, there are teams that are changing. And I talked a little bit about the transition within the unit as they move to the step-down unit or to the chronic care facility or to the CVICU. There's also another barrier is that we're often not doing a good job identifying the timing of discharge. Often it just sort of comes upon us, and then we have this mass scramble to get the patients ready for discharge. So do we have a standardized process, not only for discharge, but for identifying when kids, we think, at least identifying a time frame, even though that could change for when we anticipate them to be discharged. And then there's a need for coordination of care with subspecialists, both within the unit, say the CVICU or the chronic care facility, and then the need to coordinate care when they go home, ECI and the other subspecialists. And then the key is the parental readiness for discharge. Are they psychologically and emotionally ready for it? Are they ready? Do they have the skill sets, and do they feel comfortable with caring for a medically complex baby? And then there are a number of language barriers, and we talked a lot about the social determinants of health and those barriers that could limit their preparedness for discharge. And then once they go home, it doesn't end. So we have to then hand off this medically complex patient not only to the families, but also to the primary care provider who has very limited resources. And so how do we communicate? So typically the standard thing is to use a discharge summary, but if you look at the content of a discharge summary, it may not speak to the issues that a busy pediatrician needs to hear or read about this baby. And often discharge summaries are full of a lot of information that is unnecessary. And I've read thousands of them. And a lot of times we have all the episodes of times that they've received antibiotics or ventilator support, but that may not be the key information that the pediatrician needs to know to care for that patient. And so the other thing is, are we supporting the PCPs properly? They're dealing with these medically complex patients. Do they have the resources? Do they have access to us in the NICU to talk about these patients? How have we adequately provided that transfer of information so that they can take care of this patient? And then I talked a little bit about the subspecialty coordination and then setting up multiple appointments. One of the biggest barriers is that you have patients who have multiple subspecialty visits. So they are seeing the pulmonologist on one day, then 2 days later they're seeing the cardiologist, and then they may be seeing another specialist. And so in a matter of a week, you have these patients going to multiple visits. How can we better coordinate and cluster that care, especially if they have to travel long distances or if they have equipment? So these are the things that we have to address after discharge. And then the psychosocial support for families after. So we have the stress and anxiety and anticipation of the discharge, but then we have the issues of what support systems do they have in place at home? Do they have transportation? There may be immigration issues. There may be families that are crossing the border. So how do we address those issues? So it's a very complicated process, and all of which we have to put together in a very short period of time. And then there are hospital-specific and system challenges like staffing, delineation of roles, who does the teaching, who provides the training, and do we have a clear understanding of what's needed? And then we have the fragmentation of care in the child protection and foster care system, so how do we integrate that system? So when we look at the barriers and challenges, we basically have to move this family, the child and the parent, from a role of just where they're fearful and they're feeling out of control, to the point where they have a sense of self-efficacy, where they have a sense of that they can really comfortably and competently care for this child. And often families, there's a lot of issues going through their heads with regard to comparison of their child, their medically fragile premature baby, and the comparison to normal babies, and the sense of how they, their change and their role and expectation of their long-term outcome for their baby compared to a normal baby, and the sort of the anxiety that goes along with that. And then there's the individual caregiver mental health concerns. There's the issue of PTSD and postpartum depression, and the other chronic mental health issues that the parents are dealing with that are often triggered by the state in the NICU. And then there's just the need for education and information. And so how do we, balance all of that and come up with innovative ways to move them to the point where they feel strong enough and capable of taking care of that patient? And Alice outlined some of the stress and anxiety that the parents are feeling. They have this initial joy with the birth of their child, and then the stress of the NICU, and then there may be a sense where they're feeling a sense of optimism, and then we tell them the patient's about to go home, and then that triggers that stress and anxiety once again. So that anticipation, and how do we deal with those issues, and how do we provide that support? And these are some individual quotes from families in the same study that Alice talked about. And basically, parents feel as if that, they're in the NICU, they're there for a long period of time, and then all of a sudden they feel as if there's no way that they can take care of this patient. They feel like they don't have the skills and the resources to do that. There's a patient here where they talked about going home with a G button. And so we assume that we teach them adequately how to take care of this G button, and then they get home and they feel as if they have no resource. Who do I ask when something goes wrong? And we feel as if we're doing a good enough job in teaching them, but obviously these kind of quotes indicate that the parents are really not getting that message. Okay. So what is the historical perspective with regard to the transition process? Typically, it's been fragmented, it's been rushed, and when that happens, there's a high degree of medical errors that can occur, when medication errors, if teaching is not optimal, and these are potentially preventable errors to mitigate long-term complications. And the successful transition to discharge really takes multiple coordination of multiple specialties, both inpatient and outpatient. So what we need to do is avoid the silos of care, and we need more vertical integration of care as opposed to horizontal care. And then we also have to address the potential cost savings to optimize, when we optimize the process of care transition. So when we look at our transition processes and our protocols, some of the key metrics that we have to look at are the objectives in designing these protocols is to improve the safety of the transition process. And we have to recognize that the infant is at the highest risk in that first year after discharge. So successful transition is key. And so what we ultimately want to do is to reduce healthcare expenditures. And there have been recent studies to show that with premature babies being more likely to be readmitted in the first year of life, if we can mitigate that, we can decrease the cost, especially Medicaid spending. So transition to home needs to be safe, it needs to be timely, efficient, effective, and equitable, and definitely family-centered. So this is a potential model of care that we need to think about as we revise our transition process. And there are the 4 pillars that really need to be considered when we look at a timely, efficient, and safe transition to home. And one of the key areas is to anticipate the barriers, to establish provider continuity. We need to ensure safe follow-up, and parental preparedness. When all of that is working seamlessly, then we have timely, efficient, and safe transition of care. And I'll go back to that model in a second. So the other key factor to put into place is to have metrics, to have data metrics. And one of the things we talked about earlier is having a follow-up database, maybe a state-specific or a national database, because the lack of following these metrics consistently are potentially missed opportunities, so that we can measure the effectiveness of our transition process on readmissions, tracking and making sure that when they're discharged to a follow-up clinic, that we know that there isn't a huge gap in that care, because we don't really, when it comes to follow-up, we don't really know this patient exists until they come to that first visit. So how do we deal with that gap between discharge and follow-up, and how can we create a safe bridge of support to get them to the follow-up clinic? And then the data metrics will allow us to measure patient satisfaction and quality of life, as well as cost. And so there's always the infrastructure barriers to setting up a database, the cost, making sure that there's a centralized database, making sure there's encryption, and to really define what the minimum components are of that database. And that's something that at the state level we're working on developing. So I'm going to talk a little bit about 3 studies that have looked at the transition process and tried to identify how transition can impact long-term outcomes, and can we kind of coalesce this into sort of a quality improvement initiative so that we can kind of set up what the best practices. So this is a study by Susan Wu, who looked at a multi-centered quality collaborative on improving NICU discharge. And so their objective, their aim, was to reduce discharge-related failures within the first year of life by 50%. So it was a multi-center collaborative. These were CHCA children's hospitals. And what they did is they took a change packet. So they had a bundle that had different components in it. And so each site could identify which aspect of the bundle they wanted to use, with some basic elements of improving the post-discharge treatment, the pre-discharge teaching. There were some basic elements that all of them had to contain, but they could pick different elements of that bundle. And then they did a number of PDSA cycles. And then the outcome metrics were to look at the number of discharge-related failures and to evaluate family readiness for discharge, as well as readmission within 72 hours and 30 days after discharge. So this left panel is sort of the aggregated data where they looked at the number of failures. So the way they define failure is if they had one failure based on their follow-up assessment, that was considered a discharge-related failure. And when you look at the baseline data and then the post-intervention data, that there was a significant drop in the number of discharge-related failures. The right panel looks at different hospitals, and each hospital, as I said, picks a different element of that bundle. And you can see just in general, when you look at all 4 panels, there was a significant drop when you look at these run charts in their discharge-related failure rates. So we know that just having a bundle, we haven't really identified which component of the bundle is optimal, but the idea of having some organized, standardized process can decrease failure rates. And some of the data that they looked at, they looked at overall discharge-related failures. They were able to reduce that from 34 to 21%. They evaluated readiness for discharge, and they were able to improve that from 85 to 91%. They didn't see an improvement in readmission rates at 72 hours or 30 days, and they kind of indicated that there may have been some reasons for that, like seasonal variation, or individual hospitals may have focused on a particular diagnosis that may have had varying risk of readmission after discharge, so it may have gotten washed out. But other studies have shown a reduction in emergency room visits and readmissions. So basically, they concluded that participation in a collaborative like this did lower rates of transition-related failures and overall had a positive impact. And this is the Project Impact pilot study. This was more of a feasibility study that looked at hospital-to-home transition in the pediatric population. And really what they wanted to do is, could they, in a large population, implement some sort of a bundle of transition across multiple hospitals? And their primary outcome was to look at how the transition improve the family's self-efficacy? Could they manage the complex skill sets that were needed to take care of that child? And they used a teach-back method. And this was, again, a multi-site observational study. And so they ultimately concluded that there was feasibility. And what they found is through this teach-back method that they were able, through implementation of the bundle, that using teach-back, they were able to improve that process from 17 to 81%, which was probably their most significant outcome. And their ability to implement timely and complete communication with the PCP. I think there was an attempt to follow up the PCP by telephone within 48 to 72 hours, and that improved from 51 to 77%. And just a general post-discharge phone call to the family, they were able to get to at least 54%. There was over almost 3,000 patients in this population, and so almost slightly more than half of them, they were able to make a discharge phone call within a couple of days after discharge. The only thing, for some reason, I can't really understand why they weren't able to implement a checklist effectively into their workflow, but that was the only negative outcome of the study. And then the other improvement study that was evaluated was the StarNet, the Seamless Transition and Readmission Network. And this is really an expert panel that looked at a number of transition bundles to look at some of the gaps in our knowledge and potential opportunities for research and quality improvement, and to evaluate some of the key metrics that impacted readmission. So in this StarNet, they looked at a variety of both outpatient factors that are here outlined in blue and inpatient factors in yellow. And really, they tried to kind of drill it down to what's the key factor that impacts or the key metric, I should say, that it will measure the quality of a transition process. And they looked at readmission. Even though that's fraught with some problems in terms of definition, there are unplanned readmissions, there are planned readmissions that would be expected based on complexity, but they still thought that this was an important metric to include when you're measuring the quality of a transition bundle. And this is also used in the adult community, and it ultimately, as a result of this expert panel, readmission is a metric that's used in the state of Texas for Medicaid reimbursement. So any type of evaluation of your transition process should include readmission, the number of readmissions. And then there are other metrics that are listed here that can be used to evaluate the quality of a transition bundle. So there are a couple of other groups that looked particularly at the transition to home process for the premature infants. There's Vincent Smith at Harvard, who looked at a number of risk factors for readmission, including and found that there were both social and economic factors, like just more likely to be on Medicaid, non-English speaking patients, and a couple of chronic illnesses like BPD that impacted readmission. But I wanted to talk a little bit more in more detail about this study out of Brown, Betty Vor's study. It's called the Transition to Home Program for Premature Infants. And they looked at a number of emergency room visits after discharge within 90 days. And they developed, this is a very comprehensive transition model where they had a team of people focusing on the very low birth weight infant, including physicians, nurse practitioners, social workers, trained family resource specialists. Very intensive program that included the pre-discharge time period where they met with families. There was a lot of intensive teaching. They participated on weekly rounds. They did an assessment of family readiness, and they communicated directly with the PCP after identifying eligible infants who were part of that program after getting consent. And then each provider had a different role in this whole process. Then they also had an intensive post-discharge intervention that included a phone call within 48 hours, actual direct visits, not only with the PCP, but with the families. They had somebody carrying a beeper who was on 24/7 call. And then they also did some assessment of maternal mental health using the Edinburgh screener. And then they were able to link the state statistics with emergency room visits as well as rehospitalization. So all the patients that were enrolled in this THP program, they could track them after discharge and determine how many kids were coming back. And basically what they found is about 20% of their preterm infants had readmissions or had ER visits. And obviously, as we'd expect, the smaller preterm infants had a higher rate of emergency room visits. But this 20% represented a 33% decrease overall of ER visits over the 3 years of the study. And this study was funded by the state. And they found that the major risk factors for ER visits were environmental, more likely to be Medicaid population, not non-white, non-English speaking, less than a high school education, but a high percentage had mental health issues. So they consider these preventable reasons for emergency room visits and really allows you to focus on where the emphasis should be as we begin to focus on the transition process and develop best practices. And obviously, more likely, the preterm infants were readmitted or had emergency room visits who had respiratory illnesses. But the other thing that they did at the end of this 3 years is they looked at the economic impact of this THP program. We know that the financial burden of and I don't really mean to use the word burden in a pejorative sense, but the preterm birth, that represents about $20 billion annually to the healthcare system, half of which are covered by Medicaid. So they wanted to evaluate the impact of this THP program on total Medicaid spending. And so what they did is they got claims data over a 24-month period after discharge, and they divided it up into 8 quarters. And they found, as a result, that there was lower Medicaid spending overall per 3-month quarter, so almost $5,000 per infant over each 3-month period, which translated into almost a $6 million a year savings in Medicaid spending. And they all, as I showed before, there was a decreased number of emergency room visits and readmissions. So when you look at return on investment, this certainly, and this, not every state can implement such an intensive program, but it demonstrates how if you optimize the transition process and really pay close attention to this, not only does it improve outcomes, not only does it improve patient satisfaction and addresses some of the psychosocial needs, but there is a cost savings. So when we go back to this model of care, when you look at these 4 pillars, how can we implement strategies? And these are just examples. So anticipating discharge. And I'll talk about it a little bit at UT Southwestern. What they're doing is they're trying to, through their EPIC system, trying to identify when the patient is more likely to go home. And then they have a roadmap and triggers internal to the EPIC system to identify when to implement certain elements of their preparation process for discharge, knowing that we have a certain target. You know, it could change, but if you can anticipate that discharge, then you can begin the preparation so it's not rushed. And then obviously getting the provider involved in having that continuity as early as possible. So just like the THP program, they're talking to the providers before discharge, especially that medically complex patient making that phone call, as opposed to just sending out the discharge summary. And then at our institution and some others, there are core teams that are developed around specific complex diagnoses, like a BPD team or an ECMO team, so that process can be optimized. And then other examples, obviously, with parent preparedness, really addressing what are the educational tools? Have you addressed literacy issues, language issues? How is that information being transferred? And are we giving the families enough time to develop those skill sets? And then, obviously, engaging follow-up and making sure we identify those kids who are candidates for follow-up, making sure they have those appointments, and even having the follow-up team come meet the families before discharge and addressing all the other subspecialty appointments that need to be made. And having some sort of alert system built into your state system so that you know when these kids are coming back to the hospital. So I was just going to give you a couple of examples of the transition bundles that are used at different hospitals, such as ours. Our process is called the NICU Basics program. And this is sort of a classroom direct teaching program. This is a modification of what had been done previously. We had a flight plan that was mostly nurse-based with some direct teaching, but this is a class, transition classes that are held on a weekly basis, now twice a week, but we're about to include several more to cover the different time periods, evening classes and early morning classes to capture as many families as possible. And then using materials that are Spanish translated. And we have a discharge coordinator who meets with the families as soon after admission, depending on the clinical status of the patient. And all of the families are invited to the NICU Basics course after admission once they're stable, or they're given a flyer at the bedside if they're not there. On average, we have about 6 to 14 families attend the classes each week. And we're also looking at a current name change because NICU Basics sounds too much like normal newborn care, and a lot of families need a little bit more in-depth, and so we're thinking about adding an educational bundle that includes the complex patients. So this is the array of topics that are covered in the NICU Basics class, and we also have a discharge checklist that covers not so much based on time, but based on systems of things that need to be done before discharge to make sure that nothing gets missed. And then obviously their appointments are being made and listed out, and so there are a variety of topics that cover some of the key things to prepare them. And again, we're thinking about adding a bundle that covers more complex care. And the other focus, the period of purple crying, to address the stressors that could lead to SIDS. And then these patients are then sent to our follow-up clinic, our NEST clinic, and there's a variety of eligibility criteria to come to the NEST clinic. And the NEST clinic is a comprehensive multidisciplinary developmental clinic. It is a developmental medical home where we do developmental assessments, but we have nutrition, we have social work, we have a family support person, we have a behavioral health person, and then we're part of the Healthy Steps program, so there's a lot of psychological support and assessments of social determinants of health to provide that psychosocial support for the families. And then the UT Southwestern system has a similar program. They have one that's based on time, so they're anticipating that anticipation of discharge. So it gets triggered. It's over a 7-day period where they have a number of different interventions at each day. Once that day one is triggered and anticipating within about a week or two of discharge, there are a number of different interventions that are triggered through their EPIC system. And they have started to leverage EPIC to make sure those elements are being done, and that they can identify those kids who are eligible for their follow-up program. They have what's called the Passport to Home program, and they go over some of the similar topics that I talked about that we do at Cook's, and it's kind of a checklist to make sure all of it's done and identifying which members of the healthcare team provide that teaching. And then they also have an alert system within their EPIC to make sure the providers know who's eligible for their follow-up program. And their program, as Dr. Savani mentioned, is the Thrive program. So if you're looking to optimize your transition process, there are a number of different toolkits and bundles that you can compare and try to get some additional ideas. Through the Ohio Perinatal Collaborative, they have a nice comprehensive toolkit. The Agency for Healthcare Research and Quality also has a resource toolkit that you can use that can give you kind of a model to compare. And then the Vermont Oxford does have a QI initiative that's ongoing. I think it started last year around transition of care. And the thing that I would like to see is for us to identify what are, and the many of these quality initiatives have taken bundles where people could randomly choose, but if we could figure out which element of the transition process that's key to improve outcomes and decrease emergency room visits so that there's commonality across institutions, and if we do a quality improvement initiative at a state level, we know what the key metrics are as well as the best practices are. So we'll see what comes of this from Oxford Network. So, you know, the real emphasis here is that we have some sort of comprehensive support system in place to address the ever-increasing population of complex premature infants, so that we can optimize the transition process, make sure the outcomes are improved and decrease readmission rates, and ultimately be a cost savings. And the key in any transition bundle is that there's family engagement, so that they are empowered. And I think that we can think as a TCHMB initiative in the future to have a statewide, a state-specific quality improvement project around transition of care. Okay, and I'll take questions. Okay. Okay.
Thank you for that. That's
Okay.
been great. I don't think this is working.
You want to use this?
Dr. Spear, I'm going to open up questions. Speak up while we get the microphone working.
In your transitions of care, I noted that one of the slides talked about throughput, and I'm presuming that's throughput in the unit while you're getting the baby ready for care.
Right, because as you know, there are a lot of moving parts during their NICU stay, from level 3 or the acute levels of care to the step-down unit, or if the patients are being transferred to the CVICU or to the chronic care facility or unit, if they have trachs and vents, they may be going to different parts of the hospital.
Have a czar that sort of looks over the shoulders of the throughputees?
There is no czar.
For example,
Okay.
you know, in our large unit, we have sometimes a terrible time getting a G-tube actually placed. The surgical resident will come by, say, oh yes, needs a G-tube, but they don't time it. They don't schedule it. And so one of us, me, calls the surgeon, who then picks on his colleagues to get the dang thing scheduled. And that can be up to a week to 10 days if you don't intervene in that process. And granted, we're a large unit, and I think probably smaller units don't have that problem, but it is one. The other problem that we've seen is a persistent perniciousness of high-flow cannulas that aren't high-flow and that are delivering room air.
Okay.
There seems to be a bonding between the practitioner and the high-flow cannula.
Okay.
I'm serious. And so what we've done at Texas Children's is we have a flow medical director. That's me. So once a week, we identify patients who are 5 months or older, who's still there in chronic disease, and what do they need to move them through the process.
Right.
We've also established discord coordinators, which don't work for the hospital, they work for the neo section. So they're ours, and they deal with neo baby needs. And they are really helpful at establishing appointments, talking to,
Right.
arranging for PCPs, a variety of things. And they have an expertise that is focused on moving patients through the system and trying to address some of the issues that you noted in your talk. Part of the problem is this process is so complex that you do need experts in
Right.
how to do this. Leaving it up to the individual neonatologist is fraught with hazard.
Well, clearly, as you've identified, it would take a lot of resources to do that. Since my training, we were talking about discharge starts at admission. We always gave lip service to that. But really, even now, it's still, even when you start a week or two before discharge, that may not be enough. So we really do need to start early in how to put those moving parts together and who does that, who is the czar, who can kind of keep all of these elements together to make sure we're moving through the process. And I like the idea of using EPIC, the triggers and best practice alerts that pop up at certain intervals may be one way of leveraging that. But you still have to have somebody to do it, and who is the designated person or group of people. I think it's probably a multiple specialty team or multidisciplinary team that needs to execute that. I think, Jonathan, you had.
Yeah. Can everybody hear me? Good. So, Yvette, thank you for doing our follow-up program in
Yeah.
Fort Worth. It was a Herculean task to start this up, and we really appreciate you. I'd just like to point out that, I know you're thinking about this, but just for everybody in the room, I think there's a unique opportunity, given where we're at with perinatal collaboration in this state, that once we hopefully get a standardized, agreed-upon data set for maternal and neonatal
Right.
issues that are usually hospital-based, wouldn't it be grand if we could also deploy a community health component, which is a section of the TCHMB, to really address standardized data collection for complex NICU follow-up patients that then could feed back into this whole idea, which I'm preaching to the choir for you.
You're definitely preaching to the choir.
But I think it's just wonderful, and I know you're working on this, and I
Right.
fully support you.
And just for everybody's benefit, Dr. Savani and I are actually addressing this issue on multiple levels. We're part of the CHND network, we're part of NEON, and then we recently had a conversation with the CP network. And basically, and we've even talked to the Canadians, who have a very robust follow-up network. So basically trying to come up with a minimum data set and trying to identify what the elements are that will align all of those so they can talk to each other, so that we can benchmark and monitor the continuum of care from prenatal to perinatal, NICU, and follow-up, so that we can then begin to address some of these issues. It still doesn't necessarily address that process of how we get them out of the NICU in a way that's safe and efficient and timely. Is there, one way to do that? Probably not, but are there some basic minimum elements, like I was trying to allude to, that should be included? But yes, that is coming, and we're hoping to get some support from TCHMB, and I think there's some positive signs that we might get some support at that level.
Well, it'll help. I hear here. So.
But I was happy to hear Dr. Stevener and the whole discussion of follow-up support. I wanted to just give a shout out to Dr. Stevener, Dr. Nedrolo, and Cook Children's for supporting the start of our follow-up program from scratch.
So Yvette, I had a question actually.
Yeah.
One thing that we've found sort of challenging is, and I don't think either Alice or you mentioned it, is an evaluation of the home that this baby is going to go to. And we have an army of social workers, et cetera, that are doing this, but to get an accurate sense of what is happening in the home is really tough.
I'm glad you brought that up, because just being at this meeting, I've learned a lot about what's there. I don't think we have to reinvent the wheel. And there was a representative of the Texas Health Partnership, or Parent Infant Nurse Family Partnership, that's what it is.
And you guys have Family Connects in Fort Worth too.
Right.
Too as well. That they are going in and doing full needs assessments in the
Right.
home and integrating quite nicely with kids' children.
Right, and there's a doula program. So there are a number of programs that are already in existence, and I think it's really just knowing these programs are out there and connecting, so that that bridge can have much more support and scaffold to it. We don't have to recreate it. It exists, and that's really an important element.
And I'll take the last thing, because I don't think there's anyone else.
Oh, Doctor.
Oh, you do? Okay.
First of all, I want to thank you, and I want to thank Alice, and also TCHMB for having this discussion. This has always been something that has been very important to me because I see babies that go home with complications. So the first thing I really appreciate is the fact that when a child goes home and there's a readmission, how do we get that data in the state? For example, if we're at Texas Children's or Memorial Hermann in Houston, and there are other places that when a patient is discharged, they may go to many different emergency rooms. So we don't always get that information back. So connecting to the state and having that piece of information is critical.
Right.
The other thing is, I think you showed the transitional program that was done it was done at Texas Children's. Anyway, one of the things that I think is also important when you're sending a baby home, especially a critical baby, a post-premature baby, is that we remember that you have some sort of a booklet where they have all of their problem lists, their issues that they've already had, the medication list, because many times these babies go to the emergency room and they need something to grab immediately. So I think that is a very helpful piece.
And we often will use the discharge summary to serve that purpose, but I don't think it's enough. It doesn't really convey it in a nutshell. Right. And then how do you generate that folder? Can it be automatically generated or created through the after visit summary if you have Epic? Can it be electronically pulled within the EHR? And as far as the linkage to emergency room visits and readmissions, we are talking about some of the common key identifiers that are necessary so that we can track them, so that when there are name changes or when they are readmitted outside of your system, we can still collate them and identify them.
And I'm here to testify that Dr. Spear does go around.
He does. That's why he can't retire.
So, in the interest of getting you guys to lunch, I want to thank Yvette Johnson and Alice Gong for their really great presentations. Thank you for the